Bismillahirrahmanirrahim. Assalamu alaikum everyone. My name is Dr. Mubashra and I am working as a consultant internal medicine. If you are new to my channel, please subscribe for more updates regarding medicine. So today we are going to discuss a very important emergency in medicine, that is DKA, Diabetic Ketoacidosis. So let's start. In this video, I will discuss about mechanism of DKA, its presentation, triggers of DKA, diagnosis, criteria of severe DKA, management, flow sheet and complications. So please watch my video till the end. So what happens in DKA? Since we all know that DKA is primarily a complication of type 1 diabetes mellitus, but it can occur in type 2 diabetics as well who have severe illness like sepsis and trauma. So there is insulin deficiency as well as increase in counter-regulatory hormones, that is glucagon, catecholamines and cortisol. This leads to metabolism of triglycerides and amino acids instead of glucose for energy. Hence, there is overproduction of beta-hydroxybutyric acid, acetoacetic acid and acetone, which ultimately leads to acidosis. Due to overproduction of acetone, there is fruity breath in the patients of DKA. Early recognition and treatment is important because the combination of acidosis and hyperglycemia can be fatal. So what is the presentation of DKA? DKA may be the initial manifestation of type 1 diabetes. It is a life-threatening medical emergency. It is one of the serious complications of insulin pump therapy. DKA is usually preceded by 1 to 2 days of polyuria and polydipsia associated with fatigue, nausea and vomiting. If untreated, mental stupor can lead to coma. Unexplained weight loss, vomiting, abdominal pain, polyuria, polydipsia, lethargy, anorexia and dehydration are common symptoms of DKA. Rapid deep breathing, which is known as cosmal hyperventilation, is also a common presentation of DKA. So we should check blood sugar level of all diabetic patients who are unwell. Now let's discuss about the triggers of DKA. These can include infections, surgery, myocardial infarction, pancreatitis, wrong insulin dose or insulin non-adherence, and medications such as corticosteroids, calcineurin inhibitors, thiazides, antipsychotics and SGLT2 inhibitors. Now what are the types of DKA? According to severity, DKA can be classified into mild, moderate and severe DKA. Mild DKA, patients are alert and have pH level between 7.25 and 7.3 and beta-hydroxybutyrate levels of 3 to 4 millimole per liter. In moderate DKA, patients are either alert or a little drowsy and pH level is between 7 to 7.24 and beta-hydroxybutyrate level is 4 to 8 millimole per liter. In severe DKA, patients are stuporous and pH is less than 7 and beta-hydroxybutyrate level is greater than 8 millimole per liter. Patients with mild DKA can be treated in emergency department. However, patients with moderate to severe DKA requires ICU admission. So what is the diagnosis of DKA? First of all, there is metabolic acidosis, that is pH is less than 7.3 or bicarb is less than 15 millimole per liter. There is hyperglycemia, blood sugar level more than 11 millimole per liter or more than 250 milligram per deciliter. And there is ketonemia, that is more than 3 millimole per liter ketone levels or significant ketonuria, that is more than 2 plus on urine dipstick. Now let's discuss the criteria of severe diabetic ketoacidosis. Number 1, blood ketone levels of more than 6 millimole per liter, bicarb level less than 10 millimole per liter, arterial pH or venous pH less than 7, anion gap more than 16, serum potassium less than 3.5 millimole per liter, oxygen saturation less than 92%, systolic blood pressure of less than 90 millimeter of mercury and pulse less than 60 or more than 100. It means that only one or more of the following if present, we will classify it as severe DKA. Now let's discuss what are the therapeutic goals in treatment of DKA. These include restore plasma volume, restore tissue perfusion, restore blood sugar level, that is reduce the blood glucose towards normal, reduce osmolality towards normal, correct acidosis, replenish electrolyte loss, and identify and treat the precipitating cause. Management of DKA. This includes airway and breathing, restore circulatory volume, insulin therapy, and potassium replacement. We will discuss these one by one. So first of all, airway and breathing. Ensure safe airway if GCS is less than 12. Give oxygen if the patient has hypoxia and investigate for the cause of hypoxia, that is infections or venous thromboembolism. Then the second step is restore circulatory volume, that is fluid replacement. In most patients with DKA, the fluid deficit is 4 to 5 liter. Initially, 0.9% normal saline is the solution of choice to help expand the contracted vascular volume. If systolic blood pressure is less than 90 mm of mercury, 500 ml normal saline is given over 10 to 15 minutes and then review. If still systolic blood pressure is less than 90 mm of mercury, repeat the same, that is give 500 ml normal saline over 10 to 15 minutes. However, if systolic blood pressure is more than 90 mm of mercury, give 1000 ml normal saline over 1 hour. The fluid formula is that fluids are usually given like 1, 2, 2, 4, 4 and so on. That is 1 liter normal saline over 1 hour, then 1 liter normal saline over 2 hours, then again 1 liter normal saline over 2 hours, and then 1 liter normal saline over 4 hours, and adjust the volume according to the clinical review, age, ischemic heart disease, chronic kidney disease, and other comorbidities. After the first 2 liters of fluid which have been given, the IV infusion rate should be 300 to 400 ml per hour. The fluid of choice is normal saline 0.9% unless the serum sodium is more than 150 milliequivalent per liter, when 0.45%, that is half normal saline solution, should be used. The volume status should be carefully monitored clinically. Failure to give enough volume replacement to restore normal perfusion is one of the most serious therapeutic shortcomings which adversely affect the satisfactory recovery. Now the question is, how much fluid should be given initially? At least 3 to 4 liters of fluid should be given in 8 hours. However, excessive fluid replacement, that is more than 5 liters in 8 hours, may contribute to ARDS, that is acute respiratory distress syndrome, or cerebral edema. When blood glucose level falls to approximately 250 mg per deciliter or 13.9 millimole per liter, then the fluid should be changed to dextrose-based solution. This helps in maintenance of serum glucose in the range of 250 to 300 mg per deciliter, and it will prevent the development of hypoglycemia and also decrease the chance of cerebral edema, which could result from too rapid decline of blood glucose. Dextrose solution is given at 125 ml per hour, and usually 10% dextrose water is preferred. Now let's discuss about insulin. After fluids, the most important thing is insulin therapy. You will immediately start insulin infusion after initiation of fluid replacement. Prepare 50 units human soluble insulin in 50 ml normal saline. Insulin infusion is given at fixed rate at 0.1 units per kg per hour. Along with insulin infusion, continue regular long-acting insulin, that is for example glargine, detamers and degludec at usual doses and times which the patient is already taking. This continuation of their shortcut basal insulin means that lower doses of IV insulin will be needed and there will be a smoother transition from IV insulin infusion to subcutaneous regime. Insulin can be given IV, that is regular insulin can be given IV in a loading dose of 0.1 units per kg as a bolus to prime the tissue insulin receptors. However, a randomized controlled trial showed that a bolus dose is not required if the patients are already taking early infusion of insulin at 0.1 units per kg. Replacement of insulin helps in correction of acidosis by reducing the flux of fatty acids to the liver, reducing ketone production by the liver, and also removal of ketones from the blood. Insulin treatment also reduces the hyperosmolality by reducing the hyperglycemia. Insulin dose should be adjusted to lower the glucose concentration by about 50 to 70 mg per deciliter per hour and decrease the insulin at 0.05 units per kg per hour when the blood glucose is less than 250 mg per deciliter. Now there are certain questions for you. So the first question is, if the plasma glucose level fails to fall at least 10% in the first hour, what is the next step? The answer is repeat IV loading dose of insulin at 0.1 units per kg. However, if still plasma glucose level remains high after first 2 loading doses of insulin, what could be the cause and what is your next treatment strategy? The cause can be immune insulin resistance and the treatment is double the insulin dose every 2 to 4 hours. However, if clinical circumstances prevent the use of an insulin infusion, what is your treatment strategy? The answer is intramuscular insulin. An initial 0.15 units per kg of regular insulin is given intravascularly and at the same time the same dose is given intramuscularly. Subsequently, regular insulin is given IM, that is intramuscularly, and on hourly basis at a dose of 0.1 units per kg until the blood glucose falls to around 250 mg per deciliter, and then the insulin can be given subcutaneously. Now let's discuss about potassium replacement. Total body potassium loss due to polyuria and vomiting can be as high as 200 milliequivalent. However, because of shift of potassium from the cells into the extracellular space as a consequence of acidosis, serum potassium is usually normal or slightly elevated before the start of treatment. As the acidosis is corrected, potassium flows back into the cell and there is hypokalemia development if potassium replacement is not done. If the if the patient has normal urine output, KCl is given in the dose of 10 to 30 milliequivalent per hour and it should be infused during the second and third hour after starting therapy, as soon as the acidosis starts to resolve. Treatment should be started sooner if initial serum potassium is low, but it should be delayed if the patient has chronic kidney disease and he fails to respond to initial therapy and serum potassium remains above 5 milliequivalent per liter. ECG can help in monitoring the patient's potassium status. High peak T waves are a sign of hyperkalemia and flattened T waves with U waves are a sign of hypokalemia. Foods high in potassium should be prescribed when the patient has recovered sufficiently to take food orally. Tomato juice has 14 milliequivalent of potassium and medium-sized banana provides potassium of about 10 milliequivalent. Now, very important step is assess and monitor. Assess for vital signs, oxygen saturation, GCS, and full clinical examination. Investigate in the form of capillary and lab glucose, venous blood gases, urea and electrolytes, full blood count, blood culture, ECG, chest X-ray, and midstream urine. Capillary blood glucose and ketones should be monitored every hour. Serum potassium and bicarb at 1 hour basis and then 2 hourly. and plasma electrolytes every 4 hourly. Catheterize the patient if there is no urine output at 1 hour. Now let's discuss about sodium bicarb therapy. The use of soda bicarb in management of DKA has been questioned since clinical benefit was not demonstrated in a randomized controlled trial and due to some potentially harmful consequences, like for example development of hypokalemia due to rapid shift of potassium into the cells if acidosis is overcorrected. Another harmful consequence is tissue anoxia due to reduced dissociation of oxygen from hemoglobin when acidosis is rapidly reversed. Cerebral acidosis can occur which result from lowering of CSF pH. However, it is recommended that bicarb should be administered in DKA if arterial blood pH is less than 7 with careful monitoring to prevent overcorrection. It should not be given if pH is 7.1 or greater because additional bicarb would increase the risk of rebound metabolic alkalosis as ketones are metabolized. Alkalosis shifts the potassium from serum into the cells, which could precipitate a fatal cardiac arrhythmia. Now the question is how to give soda bicarb in DKA with severe acidosis. 1 or 2 ampoules of soda bicarb are added to 1 liter of half normal saline with 20 milliequivalent KCl and infused over 1 to 2 hours. Or instead of half normal saline, 400 ml of sterile water can be used. Addition of soda bicarb to 0.9% saline, that is normal saline, would produce hypertonic solution which can aggravate hyperosmolar state. Phosphate replacement is rarely required in treatment of DKA, but treatment of associated infection is important in diabetic ketoacidosis. Gastric intubation is recommended in comatose patients of DKA to prevent vomiting and aspiration that may occur as a result of gastric atony, which is a common complication of DKA. Indwelling urinary catheter may also be necessary, and CVP line should be inserted in patients with pre-existing heart disease or kidney failure or those with severe cardiovascular collapse. In those patients, CVP catheter should be inserted to evaluate the degree of hypovolemia and to monitor fluid administration. A comprehensive flow sheet should be maintained by the clinician who is responsible for patient care. It includes vital signs, serial lab data, and therapeutic interventions, for example, insulin, fluids, plasma glucose should be recorded on hourly basis and electrolyte and pH at 2 to 3 hourly basis during initial treatment period. Bedside glucometer should be used to titrate the insulin therapy. And patients should not receive sedatives or opioids in order to avoid signs and symptoms of impending cerebral edema. Now let's discuss about the transition to insulin regime. Once the DKA is controlled and the patient is awake and able to eat, subcutaneous insulin therapy can be initiated. Patients with type 1 diabetes may have persistent significant tissue insulin resistance and they may require a total daily insulin dose of approximately 0.6 units per kg. The amount of insulin required in previous 8 hours can also be helpful in estimating initial insulin doses. Half the total daily dose can be given as a long-acting basal insulin and the other half as short-acting insulin pre-meals. The patient should receive subcutaneous basal insulin and rapid-acting insulin analog with the first meal and insulin infusion discontinued almost an hour later. The overlap of subcutaneous insulin and insulin infusion is necessary to prevent the relapse of DKA. In patients with pre-existing diabetes, giving their basal insulin by subcutaneous injection at initiation of treatment simplifies the transition from IV to subcutaneous regime. The increased insulin resistance is only present for a few days, and it is important to reduce both basal and bolus insulin to avoid hypoglycemia. A patient with new onset type 1 diabetes usually have significant beta cell function and may not need any basal insulin and only very low doses of rapid acting insulin before meal after recovery from DKA. Patients with type 2 diabetes and DKA due to severe illness may initially require insulin therapy, but they can often transition back to oral agents during OPD follow-up. So this is all about DKA. I hope that it is helpful for you. Please like, share and subscribe to my channel for more useful stuff regarding medicine. Stay blessed. Allah Hafiz.